I've used lasers in my practice about 6 years now. I'm most familiar with CO2 wavelengths. I have also used KTP wavelengths. I have used ND-YAG and holmium wavelengths as well in different situations. The biggest difference that I've seen with the CO2 lasers currently, I think, relates to the pulsing technology and the decrease in char formation. I have a more precise cut and a better visualization of the anatomy, and that allows me to make more definitive cuts that allow me to start and stop the operation with greater definition of the underlying structures.
In my work as the director of the endoscopic and minimally invasive program at MD Anderson, I've been using lasers now for about 8 years, really strictly related to the practice of head and neck surgical oncology. I have a small benign practice, but really I use the digital AccuBlade and CO2 lasers exclusively in the treatment of laryngeal and pharyngeal cancers.
I've used lasers in my practice since I finished residency and began my laryngology training and fellowship. So since 1992, I've used different lasers. And primarily, though, the surgical laser that I've used is the CO2 laser. I've also had experience with the ND-YAG, the KTP, the pulse dye laser.
Regarding laser, I'm used to work with laser since '84. And I started with the CO2 wavelength. So all over the years I had the chance to work with other wavelengths like the ND-YAG, after that the KTP and the diode lasers. But the CO2 is still my workhorse. So let's say in the department that 95% of the cases are performed with the CO2. And from time to time we are still using the diode, but not that frequently.
I think the CO2 laser is best utilized in a variety of procedures in which I need access to areas that are difficult to access through a small access portal, usually a laryngoscope in my situation, and I need a very precise treatment of tissue, either for cutting or for ablation. In ablation situations, probably the most common being respiratory papillomatosis. I like using the CO2 laser for ablation of these lesions, as I feel I can get a more precise depth of ablation and eliminate injury to the underlying lamina propria of the vocal folds. In other scenarios, I like the CO2 laser in particular for cutting, and I find that it cuts tissue, particularly scar tissue, quite well. And so those are the two primary modes in which I'm using that. I'll also use it for cutting muscle tissue in the case of Zenker's diverticulum, for example. And there I like the precision in being able to cut the muscles and see the muscle fibers being cut without a great deal of char, knowing that I've completely divided the muscle at the conclusion of the procedure.
So I have been using over the last 4 years the digital AccuBlade made by Lumenis, and it has completely transformed my practice in transoral laser microsurgery, in particular for glottic and laryngeal malignancies. I am a robotic surgeon as well. I've used robotic surgery for a lot of oropharyngeal cancers, but I feel that the digital AccuBlade is really indispensable for providing optimal oncologic results as well as superior functional results after transoral laser microsurgery for the treatment of larynx cancer.
Regarding the laser technology, we are used to work with the CO2 laser since 1984. And all over the years we had the chance to work with the ND-YAG laser and then the KTP laser and also the diode lasers. But I must say that the CO2 laser is the workhorse, and 95% of the cases are certainly performed with the CO2 laser these days.